I presented at the EHA meeting an abstract on the combination of venetoclax and navitoclax in patients with relapsed refractory ALL. The unmet need is that patients with ALL, when they relapse, the outcome is really poor, and that is significant in adult, more significant in adult patients, where the survival at best is 7 months. We know that in cell lines, these ALL cell lines rely on BCL2 pathways, means the cells are not dying. There's data showing that inhibition of BCL2 and B6L can be of benefit. And when we combine them together, we can have synergistic activities. And it will allow us to use lower dose of navitoclax, because by itself, navitoclax being a BCL2, B6L inhibitor, it can cause thrombocytopenia. So the combination, it will provide two benefits. One is the synergistic activity. Second, it will allow to reduce the dose of navitoclax and thus improve on the rate of thrombocytopenia. So we designed this study for pediatric and adult patients who failed prior therapies. And then the regimen at the beginning was given with venetoclax and navitoclax, and from day 9 and onward, we can add chemotherapy. Down the road, the protocol was amended, and chemotherapy was permitted to be added from day 1. We enrolled 47 patients who failed multiple things, including CAR T cells, blinatumomab, inotuzumab, and allogeneic bone marrow transplant. In this heavily pretreated population, we did see good response rate, 60% response rate, and more than half of the responders achieved an MRD negativity, which is good. The toxicity profile was manageable, and the dose recommended for the phase 2 was 50 milligram per day of navitoclax on a 21-day dose schedule for people who are 45 kilograms and above, and 25 for patients who are less than 45 kilograms of weight, 21-day schedule. So right now we're moving into an expansion phase where we're combining venetoclax, navitoclax plus chemotherapy from day 1, and we're giving a 21-day dose schedule. Therefore, we give a break, allowing the count to recover. In this study, the median overall survival was 7.8 months, with a better outcome in B cell compared to TCILL. When we did RNA sequencing on this patient and profiling, we did see an activity across the board. And then we did BHC profiling as well, showing that T cells are more reliant on a BCL2 pathways, where the B cells can be on a B6L and BCL2. So these findings in a patient population heavily pretreated, I think, are significant and warrant further evaluation of these compounds in ALS.